I'm Kathy Andrus, and I started at the Pioneer Memorial Hospital in 1975 as a newly graduated nurse. So what a wonderful place to learn everything about all the different types of care. We took care of everything from the ER to surgery to OB in those days. There was one long linoleum hall. So you could stand at one end in the ER, where the ER doors were, and you could see clear down to OB. There was a small little offshoot with some 6-bed wards that patients would be in. There were no private rooms. All of the rooms were double or men's or women's wards. When I started, I worked nights, so there was only one registered nurse on in the whole hospital all night long. I had a couple of LPNs and then some aides to help us out. And so the ER wasn't staffed. It was just a one-room that had a gurney in it and a doorbell. So people would come up to the end of the hospital, pull up in their car, and ring the doorbell, and we'd hear the doorbell throughout the whole hospital. And so I'd usually take someone down, usually a male. If I had a male orderly, I'd take him down with me because you had no idea what you were going to find. So you'd go down, and it was everything from, it can be a gunshot to the foot of someone out target practicing, or usually it was simple things like lacerations or broken bones. We didn't get a whole lot of sick kids or people at that time that would come to the ER. It was a small enough community that people knew where their doctors lived. They knew their phone numbers. So if they had a cold or needed some medication, they'd call their doctor up directly. They wouldn't come through the ER and wait to be seen by another doctor. They'd just go over to their home or call the doctor. So more often than not, we'd have a doctor call up and say, hey, would you give Mrs. Jones a shot of antibiotics or a pain shot or something like that, and they'd walk in the front door and we'd give them the injection and they'd walk out. In OB, it was a different story. We had an LPN who manned the labor rooms and all of the OB area. So, and I had some wonderful RNs there, LPNs there. It's a good thing because as a new graduate, I didn't know a whole lot about labor and delivery. But they would take care of the laboring patient until it was time to call the doctor and me, and we'd both come down together. I'd stand and watch the baby born, and then I'd leave, and the LPN would take over. We only had a handful of doctors at that time, so I think there were probably less than 10 when I was there, and even our anesthesia was delivered by an anesthetist, so a nurse instead of an MD. There was one CCU room, so one coronary care room that was just off the nurse's station. It was a 2-bed ward, and so whenever we would have a heart patient, we did have one cardiologist at that time, we'd have a heart patient, and I'd have to send my LPN in to watch that heart patient. They had just monitors above the beds, no central monitor, no automatic blood pressure readings, no pulse oximeter, not any of the tests that we now have that can determine how sick these patients were. And so I'd send my LPN in, and they'd sit there at the doorway with the door open, with their eyes just wide in fright all night, just hoping that nothing would happen during the night. The kitchen was just a few steps away from the nurse's station, so when a patient needed something, we'd just go down to the kitchen, fix them a little meal, and come back and give it to them. And so we just had open access. Same with the pharmacy. The nurses had keys to the pharmacy, and we'd go in and get whatever medications we needed. Right now, patient safety is such that we barcode the medications and the patients, and we always check barcodes. Well, back then, we had just little square medication cards, and we'd carry those. We'd put them on a tray, put all the medicines in cups for the whole hospital in cups for that round and would carry this tray from room to room, giving the patients their medications out of those cups. So a little bit different. I'm sure we probably made a lot more mistakes that we weren't even aware of back then. We mixed all of our own antibiotics during the night. We'd take the little vials and put in the saline or sterile water and mix them and put them in the IVs ourselves. We didn't have a pharmacist on call or even there during the night at all. All the IV solutions were in glass bottles rather than the plastic. We didn't have IV pumps or even dial-a-flows very often in that. The dial-a-flows were just starting at that time, so we would hang the IVs and would have to count the drops with our watches to see how quickly the IVs would run or not run. And then when the patient moved their arm, of course, everything would change. And so it was a little hard to make sure that your IVs really stayed on track and they were getting the fluids that they should. I don't remember if we had wall suctions. I remember the big Gomco suction machines that would wheel into the room to attach an NG tube to or a chest tube to or something like that. So it was a wonderful time to learn, to be able to find out how to take care of all the different types of patients. But we've come a long way since then. When we moved into the new hospital and actually had an ICU, a real ICU, I think that's when I thought, wow, Dixie's really come a long way. And we took care of mostly just the cardiac patients at that time. It was still a real personable hospital. I still knew everyone. You knew all the doctors. Most of the people coming in were from the community, and you knew them. And so it made taking care of the patients, you were caring for your neighbors and your friends and your family members, which I think is a little bit different than it is now. I'm sure the nurses now taking care of patients sometimes, most of the time, don't know their patients personally. But back then, we knew those patients. We knew those people as community members. And I remember one time taking care of a gentleman who was kind of one of the old founders of the area, and he owned a grocery store. One of the larger grocery stores in town, and he'd had a fairly severe heart attack and had to be transferred up to Salt Lake. And at that time, the ambulance companies didn't have anyone who was had the skills necessary to monitor him during the transport. So they asked if I would go with them to transport him up to Salt Lake. And so I rode in the ambulance, and as we left, he asked, could I just go by my grocery store one last time? I think he knew he would never make it back. And so the ambulance driver said sure. And so we went by his grocery store and kind of slowed down as we drove by, and he looked out the window, and I think he was kind of saying goodbye to what he knew would be the last time that he'd see that. And so we took him to Salt Lake, and he did never make it back down. So I just remember that at a time when we were able to really take care of the patient, to take care of them as a person, that we were able to give them the little extra things that maybe sometimes get lost in the shuffle as we got bigger and more busy. But I think that's one of our goals, is to really take care of the patient as a person. And whenever I think about that, I think about taking that patient by his grocery store one last time.
What was the grocery store?
It was Snow's. I can't remember. He was J.C. Snow. And I can't remember the name of the grocery store. It's out where the college is. Now the college ATC thing is out there. Do you know, just north of the... Was it Harmon? It was before Harmon's. It was named... Yeah, oh yeah. I mean, that was an amazing thing.
See if we can dig a picture up or something.
Yeah.
Sorry to interrupt you.
No, that's okay. As we moved into the new hospital, one of the big pushes was to get Joint Commission accredited. And so in that first 6 months, we went through our first accreditation with Joint Commission. What that amounted to, I mean, we look at all the preparation now and we have 5 surveyors and all these days and everything that we have to do. But at that time, they did a walkthrough, a survey, made sure everything was safe, looked at all the plant functions. But then the quality portion was 3 audits that you had to do at that time. We showed them a vaginal delivery, a cholecystectomy, and a hysterectomy study that you did. And the way I was trained to do that, you'd actually take computer cards. There were no computers. I know that shocks everyone, but there were no computers that we had access to at that time. And so you actually had little computer cards with holes that were in them, and they were numbered. And if something did not pass a certain criteria, you'd take a paper punch and you'd punch through that hole so that it wasn't an enclosed hole. It had kind of an outlet. And when you got finished, you'd take a long metal stick and you'd put it through the hole and you'd shake it. And all the ones that had been punched would fall out. Hence, these were the charts that fell out. And we still use that term today, although I don't think people know where that came from. Anyway, so you did 30 charts of each one of those, and then we went in and presented that to the surveyor. I think there was only one that first time, and we passed our first Joint Commission accreditation. So I'm sure it's changed so much since then. I've been in charge of Joint Commission surveys for a lot of years, and it went from just that 3 audits, sitting down with administration in a boardroom, doing a walkthrough, to now they are really looking at, does everyone know what's going on? Does everyone know how to deliver safe patient care? Does everyone have a plan? And make sure that we're all on the same team. It's not just the managers and the directors and administration, but does everyone down to the last person walking through the door know what the plan is for the patient? And I think our care has drastically changed with the addition of all of the specialists that we have, with the training that the nurses have received. You can see our level of care is just so different than what I saw as a new graduate nurse walking into the Pioneer Memorial Hospital that first day.
How would you say we do on our surveys now?
Oh, absolutely. One thing that we've had support from administration for years is we don't gear up for surveys. They get us how we are. So that means we have to be ready all the time. They don't come and we don't put a show on for them. We show them what we are every day, whether it's a survey day or not a survey day. And we have support from administration for that we don't say, okay, we just had survey, so now we can go back to doing things the old way. We do things the right way every single time. We communicate and get people involved every single day. We don't just put on a show for a surveyor. And that's why, we're happy to be a part of this hospital and proud to be a part of this hospital, because we would come here, we'd bring our friends here and our family members here, because we know how important patient safety and quality is every day, not just on the surface. Does that make sense?
That's great. If you go back to the Pioneer Hospital,
Okay.
can you talk about its failings, things that were wrong, and why we needed to build the new hospital, and how that transition went into the new hospital?
Oh, wow. I mean, it was a county hospital, so it It didn't have, of course, a lot of budget. The beds were functioning barely. You know, the old crank-style beds that you'd have to crank up to sit a patient up or not. It had outlived its life, and I think we were ready for that next step. We were now getting more doctors, and so we needed the extra beds. I don't know what the census was like at that point. I wasn't involved in that part of it, but even just the one emergency room, just a one room for your emergency room with one gurney in it. As the town was growing, we were needing more than what was available. And then the wards, the 4 and 6 bed wards were pretty tough to be, really sick and have everyone around you. We're really spoiled now with all of our private rooms.
So how was it moving into the new Fort East campus?
Yeah.
The difference, was that nice?
Oh, it was amazing. I actually was not here on moving day. I got married that week, so I missed the whole move, which was really nice. But when I showed up, and I went straight to working in ICU, and to be able to have monitors out at the desk, to be able to watch the patients right at the desk rather than have to sit right at the bedside and watch the monitors. The equipment, we felt like we had just won the lottery or something, because all of a sudden we had the new equipment. We had beds that actually worked. And, I think as we were building that, of course, too, they didn't sink a lot of money into the Pioneer Memorial. So I'm sure for those period of months, things kind of went down just a little bit. But it was just like Christmas to have the equipment that they needed, to have more ER bays. And they were just curtained off bays, but at least we had room for more gurneys than just one.
So how did, you said you weren't here for a few years, but the time you were, what were the changes you saw as the hospital grew, and even as it moved over to the River Road campus?
I think the biggest change I've seen over the years is just our ability to take care of things. That as we'd get new providers, the bar would be raised, and we'd be able to take care of more and more difficult things. We'd be able to do surgeries here that normally you'd have to travel to Salt Lake to do, or to Vegas to do. As people got sick, we'd be able to keep them longer here, and more often keep them here without having to ship them. And I guess respond to the needs better of the community. And I think the administration has been real aggressive in looking to see what needs are we lacking, and the physician recruitment that they do to be able to fill in those gaps, and sometimes subsidizing those physicians to a degree so that we can have something here that normally we wouldn't be able to have. When people would come and talk to me about St. George, and they'd say, well, tell me about the hospital. And I'd tell them the different subspecialties and specialties of physicians that we'd have. They would be amazed, and they'd ask, what is your population? And they'd be surprised that for our population, we had as many subspecialties and specialties as we did. And I think it was because the community and Intermountain was very focused on meeting the needs of the community. Sometimes, like I said, maybe it didn't make a really good financial sense, but they were committed to bringing quality care to the community. And I think being part of Intermountain has really helped us with that.
Great. Were you here for moving day when we moved to this?
I was.
Can you tell us a little bit about that?
That was kind of a scary thing. You know, when you move into a new house, there are always those things that don't quite work right. And the fear was when you move into a house and something doesn't work right, it can be a little bit of a distraction or inconvenience. But if it doesn't work right with patient care, it can really harm patients. And so we did mock transports and what are we going to do, and we spent weeks and weeks of how is this actually going to work. And so moving day came and we were all here and everyone knew what their job was and where they were supposed to be and had the vests on and what is the order that we were going to take patients, making sure that when we moved patients that we did it slowly enough that we had time to get them settled and get them staffed, but quickly enough that we weren't spread so thin that we had stragglers behind that weren't being cared for too. And I'll tell you, the group did a fantastic, fantastic job on moving day. And I think because of all the planning that went into it, I don't think we really had any big glitches. I know we didn't have any glitches that I knew of that, and I was the risk manager, so I'd probably know, that really impacted patient care at that time.
Didn't they kind of have a big census boom right after?
Oh my gosh, yes. You know, so we had an ICU and we had thought that we would have, you know, X number of beds based on history, that we wouldn't need to fill all the beds, that we could just staff for a certain number of beds. Well, oh my gosh, right after we moved, I don't know what it was Thanksgiving time, and we had a huge influx of patients, and especially ICU patients. So we ended up having to get traveling nurses. And for quite a period of time, we had a lot of traveling nurses that would come in and especially do our specialty areas, but be in the ICU and fill in the gaps with our other patient care areas. So we no sooner got moved in than we really tested some of our fail-safe systems and did very well, actually.
Great. You told that great story about the patient you took to Salt Lake. Do you have any other great memories or stories from Dixie's past that you want to share?
I'll have to think of some. I've got a lot of stories. I can't think of any right now.
Well, that's okay.
But
The one you told was great.
Yeah, that was great. So, yeah.
So we have, you know, some of the things that make this hospital great are the people who work here and the people who are willing to do what's needed. We hear stories all the time about housekeepers who will hear that in the ER, the person coming into the ER had problems in the car and not wanting the family to have to go out and face that later, will go out and clean the car. We hear of social workers who go pick up dogs and make sure they're taken to a neighbor to be taken care of. We hear of families of staff members joining together to do Christmas for families who have had an accident and maybe the parents are in the hospital and part of the family over the holidays. It seems like every time I turn around, I hear of staff going above and beyond, and not only above and beyond, they make a connection with their patients. They see what they need and they feel that need. And I don't think you get that every place. I think we are special, and I think that's one of our special things is that our staff really do see every patient as a person, and they do what they can to make their lives better.